Take it away, Pam.
All right. Well, I'll put myself on here, drown rat looking and all. But I think it's the friendlier way to go. So hi, everybody. Good morning. So harm reduction Michigan. I think most everybody in this group has a pretty good sense of harm reduction Michigan. Eric, it's nice to meet you. I'm thinking maybe you're the new staff person with the TIMS.
Yeah, hi. Yep, I'm a BHC in southeastern Michigan. I just started like a month or two ago.
Okay, great. Welcome.
Thank you.
Welcome to the work. So it's an ever evolving thing, as we've all noticed. So just a little quick blurb on harm reduction Michigan. And then I would actually prefer to open it up to a discussion, a group discussion about how we see things and the lay of the land and how we can think about moving forward. How many people on the group chat did MDHHS's survey on what to do with the opioid settlement money? Sorry. Hold on.
They weren't very happy about the survey.
I'm going to put the blinds down and maybe they won't see the mailman. Okay, sorry about that.
That's fine.
So canines in the house. So Harm Reduction Michigan is an organization that started with a number of people who were volunteering their time 100%. Two of us had a pretty extensive history in harm reduction work nationally. And Maya, who was the closing speaker at the Rural Health Conference last Thursday, she and I were the co-founders of Harm Reduction Michigan. And probably about 2017, Maya does a lot of work consulting. And so it just got to a point where she had to dedicate herself to that. And so now it's me. And but we still work in partnership a lot on a lot of different things. But that's really how Harm Reduction Michigan started. And then we started in really 2009. We saw a lot of people dying of overdose. And it seemed pretty crazy to me because I had a lot of resources about overdose prevention at that point and nobody here was talking about it. So I knew Maya had a lot of experience with her work in Massachusetts and the early work done there by Alex Wally. And so I also was doing my internship for Grand Valley at Munson at the time. And so I partnered with Munson Behavioral Health or Munson Drug and Alcohol and Families Against Narcotics original founder, who was Mark Rudolph. And we did an event at the State Theater in Traverse City and really introduced naloxone to the community at that point. And so it was a panel with Munson Drug and Alcohol and a medical examiner from Bay County, Mark Rudolph from Families Against Narcotics, and couple other people. So long story short, it was exciting because we had 270 people come to the State Theater that night, which was just, it was just a Monday night in November. And so to have that many people walk through the door because they were concerned about what they were seeing in their community and wanted information and some ideas and some answers that weren't at that point being made available to anybody from the health department or anybody else for that matter. So that was really our first big event. At the time we were called My Whosoever, but we changed that name in about 2015 because some of the board members didn't like that connotations that had. So we changed it to Harm Reduction Michigan at that point. We got our first substantial chunk of money for doing hepatitis screening, referral, and linkage to care in about 2017 from a private foundation that sought us out because of our work in syringe access and naloxone work. And so we began doing Hep C prevention and treatment, actually not treatment at that point, but Hep C well, we were really doing treatment through an underground program out of another state, but that's another long story. So anyways, but hepatitis screening and HIV screening, we in 2019 were given Bloomberg or Vital Strategies funding to do overdose prevention work across the state. And really that money was focused more on Northwestern, Lower Michigan. We have outreach in Ypsilanti and Wayne County and downriver Detroit, but that has always been pretty restricted financially because the Vital Strategies money did not go to that part of our program. So we've been doing outreach in those communities as well as Jackson for a number of years now, but it's again pretty limited because of a lack of funding. So that's what Harm Reduction Michigan is. Of course, we're a full service harm reduction organization, meaning that harm reduction is quite a long continuum. And so that's everything from a person who wants help for whatever it is they want help with, whether that's drug use or not. We often have a lot of people come to us for help with alcoholism because, you know, right now, if anybody's looked around Traverse City, there are very few services available to people. The detox has shut down. Phoenix Hall is now shut down, I'm understanding because of COVID. And so right now, pretty much your only option for detox is Bear River or 1016. And I had this person who came seeking help with alcoholism this week tell me that they had called 1016 any number of times and not gotten anybody to answer the telephone. So in these times with COVID being so prevalent and other issues, it's difficult for some of the residential inpatient programs. And so harm reduction is for whoever needs it, and it doesn't have to be injection drug users, and it is much broader than needle exchange and naloxone distribution. That was one of my comments on the state survey, was that harm reduction is not just needle exchange and naloxone distribution. And I feel like there's a pretty substantial misunderstanding about what harm reduction is and about what harm reduction isn't. And that's kind of playing into some of the challenges. The opening speaker, David, on Monday or Thursday at the rural conference, I thought he did a very good job talking about how people don't really understand what harm reduction programming is. And so out of all of our locations, probably the broadest spectrum location is Cadillac. And that's kind of in part because of a number of factors that combined there to make that really our model program. Vital Strategies funding, and then a tremendous need for services. And so that combination of factors kind of set us up to be our kind of one-stop shop in Cadillac at this point. And so we do medication assisted treatment there. We do overdose prevention. We do naloxone distribution. We do syringe access. We do outpatient therapy. We do peer recovery support and counseling. And we also do COVID vaccinations. And so that's basically the extent of our services at this point. But, you know, I find that some of the challenges are in the fact that a lot of times people want to look at services in a finite box, and it's really more of a continuum. And sometimes, like, it'll take a long time to work with people to get them to the place where they're ready to make changes, and that the changes are not just being imposed by the criminal justice system. And I can take an example. There's a person who is really one of our lead harm reduction program peer people in our Benzie County syringe service program. And that person, when they first came to us, didn't come to us in Benzie County. They came to us in Wexford County, and they were coming to us from MESIC, and they were asking us, they came to our Cadillac location asking us to set up syringe access services in MESIC, because there were enough people in MESIC that didn't have any access to sterile syringes. And so we agreed to do that, having authority to work in Wexford County with DHD-10. Very grateful for our partnership with Angie and Kevin Hughes and Dr. Morse. And were operating in MESIC on a very limited basis with these peer people. And one of those individuals then lost their housing there and went to Benzie. So when we first started interacting with this individual in Cadillac, it was probably, I'd say, at least a year ago. So in that time, they've moved from Wexford County to Benzie County, and then started, you know, distributing supplies to their network in Benzie County. And then because of a continued problem with housing, has kind of been, you know, back and forth between Manistee County and Benzie County. And the challenges in that is that a lot of times funding is specific to one county, or for example, Benzie County, although they have the same CMH program as Manistee, they have a different health department than Manistee. And so you get, you know, we could fund that person for doing outreach work when they're in Benzie County, but we couldn't use Benzie County funds to do outreach work with that person in Manistee County. And, you know, the housing problem is a continual problem for lots of people. And so this particular individual ended up encountering some substantial violence in Benzie, and that's kind of why they ended up flipping back to Manistee. And long story short, that person is back in Benzie now. And here we are, probably a year and a half later. And we have, at that person's request, we made appointments for that individual to start MAT at their request with one of our physicians, and they didn't go. Now, this person also has transportation problems. And so, you know, finding a way for that individual, we're not funded for transportation of any sort. And but finding a way for that individual to get to their appointment. But long story short, the first time we had an appointment set up for this individual, they didn't make it and didn't call and didn't follow through to let, you know, the doctor's office know they weren't coming and that they were still interested, but they just couldn't get a ride or whatever it was that day. And so I'd have to check to see, but that appointment was probably at least 4 months ago. And so now I'm excited to say that, you know, tomorrow, that person is going to another appointment with one of our providers. One of our people is volunteering to drive out there and get that person, to bring them to their appointment. And so, you know, we continue to face these gaps in needs and are unable to access funding from the NMRE. And that's a really long story that we don't need to go into on this call. But anyways, that's a problem when the liquor tax dollars and the federal money that's supposed to go to support these programs, when they won't open their provider panel to new providers. And so we're technically a new provider and they've told us that their panel is closed, then we can't access any of that money. And so that's a challenge. And so that would be one of my first requests to the state health department would be to lift that limit on providers that each of these PIHPs have. Because what it is it's really exclusionary practices that are just reinforcing the status quo. And so we will again see an increase in overdose deaths next year because of this resistance to opening up their provider panels to new opportunities. So anyways, that's where Harm Reduction Michigan stands. You know, that's my point in that story about this participant from Benzie is that it's not a situation where a person goes into a 30-day program or a 2-week program and then comes out and works with a peer recovery support coach. And then, you know, 4 months later, they're off and having a fantastic life. I mean, I think everybody's on this call is familiar enough with this disease to know that's not how it goes. You know, this is a chronic illness, and a lot of times people require support for a very long time. And the way that we often have services parceled out, it doesn't really work that way necessarily. And so, but it's really important to have conversations like this, Suzanne, so that we can do warm handoffs you know, in Cadillac, we work really closely with Catholic Human Services because they're in the jail. And so they often need a doctor on the outside who can do buprenorphine or Vivitrol shot, and they'll bring their participants from the jail to our location in Cadillac to get a Vivitrol shot or to get Suboxone or these types of things. And so that's an example of where, you know, the partnership works really well, because if it weren't for that flow of information between the Catholic Human Services jail worker and our staff in Cadillac, then we wouldn't be able to really provide the people that we're trying to help there with everything they need, or as much as we can provide them with. And so these kinds of meetings are super helpful because they allow us to stay in conversation. And, you know, the focus of this one is Kalkaska. So, you know, we have just begun doing outreach in Kalkaska and services 1 day a week in Kalkaska. We don't have any funding for Kalkaska, so that's being donated in kind by our organization with hepatitis C funding. We do offer hepatitis C testing to anybody who comes through there, but that's why we're only 1 day a week. You know, we would like to be more than that, but can't do so without some funding of some sort. And, you know, we would apply for some Kalkaska County liquor tax dollars if that weren't an option, but it's not. So
We've actually lost some of our funding for the coalition
mhm.
in Kalkaska.
Yeah, I'm sorry to hear that.
Yeah.
So
Well, we're
anyways,
always, substance use is always the first place to go.
what's that?
Substance use is always the first place to lose money.
Yeah, that's unfortunate because it's not, it's, you know, it's growing. It's not, well, and it really shouldn't, we shouldn't be losing money. There's huge pots of money available that are just not making it down to the programs that it needs to make it to, you know, so.
And to go back a minute too, the misconception of what harm reduction is, the way that I kind of see it when I look at any and all substance use treatment is all facets of treatment are harm reduction in one way or another, whether it be residential, detox, anything, it is reducing harm. And as a person in recovery, I really see my recovery as an ongoing process of harm reduction. The way that I experience my addiction, it's always present in everything I do, whether it be shopping, candy, sweets, coffee. I mean, it's really just a process of finding that balance of minimal harm with the behaviors I engage in.
Can we step back for a minute, just because we didn't introduce everybody and who they are and who they work for? Can we go ahead and do that real quick so in the recording people know who people are? Can we start with you, Dr. McGraham?
Sure, I'm Dave McGraham. I'm a physician. I live in Traverse City. I work about half-time as the medical director of the Northern Michigan Opioid Response Consortium. We're a 21-member collaborative that assists with treatment prevention and a variety of other programs throughout the region. Nice meeting you.
All right, thank you. Grayson?
Hi, I'm Grayson. I am a person in long-term recovery and a peer recovery coach for Catholic Human Services, primarily the Central and South Central regions.
Thank you. Eric?
Hi, I'm Eric, and I work for the MOC, Michigan Opioid Collaborative, and I'm a behavioral health consultant for Southeastern Michigan.
Thank you. Tim Hudson?
Hi, I'm Tim Hudson. I'm also with the Michigan Opioid Collaborative, which is a grant-funded program with Michigan Medicine, the anesthesiology department, and the psychiatry department. I'm a behavioral health consultant for the northern 21 counties, and we focus on increasing the availability of medications for opioid use disorder, as well as treatment for any substance use disorders and Hep C.
Thank you. Angie?
Angie Galaxon, District Health Department number 10. I'm a prevention specialist in substance use prevention for Wexford and Saukey counties.
Thanks. Jen?
Hi, I'm Jen Hansen, Community Health Supervisor at District 10 Health Department.
Thank you. Kim?
You say Tim or Kim?
Kim.
Okay.
Hi, my name is Kim Johnson. I'm a person in recovery, and I am also a certified peer recovery coach.
Thanks. Tim Shucraft?
My name is Tim Shucraft. I'm also with Michigan Opioid Collaborative. I'm a peer recovery project coordinator and also a certified peer recovery coach.
All right, thanks. Belinda, you're muted too, so. Belinda, you there?
Yeah, it took me a second to unmute myself, sorry.
Okay.
Belinda, I'm just the mother of a son that has an SUD disorder.
All right, thanks. And Elizabeth is behind the Up North Prevention. She's here helping me. You want to introduce yourself?
Hi, I'm Elizabeth. And I'm from Catholic Human Services. And I am Up North Prevention with Otsego, Crawford, and Ascota.
I think we're a little too close.
Now you're muted, Suzanne.
I'm Suzanne Prentice. I'm the coordinator of Live-Well-Kalkaska Substance Free Coalition, and I work for Catholic Human Services Up North Prevention. Now let's open it up to questions. Anybody have questions for Pam? I have a question then. So a lot of times you hear that these needle exchange programs are just way of enabling people. How would you respond to that, Pam?
I would respond by saying that, no, the focus of needle exchange is public health. I think it always, and at least historically for me, which has been a long time, arguing these programs in Michigan, New York, New Jersey, Illinois, been doing this a long time. And I find that if you focus on public health, that helps a lot. So when you're dealing with population that comes to this from the substance use disorder aspect of it, then it can be really challenging and you'll get a lot of that. But you know, when you look at people and you say, well, I'm certain that you don't want to see HIV increase in your community, and you don't want to see viral hepatitis increase in your community either. I'm sure that's true. Most people will agree with you on that. And what a lot of people don't understand is that, you know, through these programs, people have a higher likelihood of going to treatment. And so that's really not well-known information. And so that's what people miss a lot. You know, that whole continuum that I talked about, it can take a really long time. So this person I was talking about from Benzie, so that's like a year and a half we've been working with that individual. And, you know, and hopefully tomorrow we'll finally see that person actually go to an appointment for MAT as chosen by themselves, not referred by the court. So a year and a half for that to happen, there are a lot of programs out here that wouldn't wait that long, you know, for that person. And that's short in the grand scheme of addressing substance use disorder issues. And so a lot of people don't realize what's behind their substance use disorder. I mean, I remember, I think I can't remember what year when I went to U of M for my undergraduate education. And I remember going to a psychiatrist there, and the guy diagnosed me with depression. And my family and I were like, depression? This guy, like, and we completely dismissed him. You know, 40 years later, he was right. Well, not 40, but almost, you know, 30 years later, I can say he was right. But we didn't understand it, you know, and so, you know, I was not court ordered at the time. It was something I was just looking for help with, you know, being a happier, more functional person in my undergraduate degree. But I really didn't understand that depression was really driving my substance use disorder. I didn't get that. And it took me decades to look back at that diagnosis and go, yeah, that guy was right. Only we didn't pay any attention to him. And I didn't have the court system breathing down my neck. And I didn't have parents who understood it, even though it was a family pattern. You know, I had a mother with pretty severe depression. At the time, it was not recognized as such. But when you're raised by a mother with depression, you have a very good chance of having depression. And so, like I said, we didn't recognize it in me or her at the time. It took, you know, my being involved in this profession and getting a master's in social work and doing a lot of very hard work on myself and, you know, involved in the field. And as I look at the lay of the land out here, you know, that's often not recognized in people that have substance use disorder. You know, like even on back to that survey, you know, it bothered me that a lot of mental health was not a part of that survey, you know, and that was one of the comments that I included was that, you know, a lot of times when you get not any substance use disorder, but when a person has a substance use disorder to the point of chaos, to the point that substance use disorder is driving all their day in their life, and there's probably a mental health disorder behind it. And it could be PTSD, it could be ADHD, it could be, you know, it doesn't have to be schizophrenia. It can be depression, anxiety, ADHD, PTSD, or a combination of those things, you know, and oftentimes it's really not recognized.
Right. I actually blew that survey up with the same thing, the mental health issue, because I think that's where we lack so much services, is trying to get someone with a substance use disorder help for the underlying condition, because when they go into the ER, they are focusing on the substance use disorder and won't look at the mental health issue. And then they go to get, you know, into treatment if they can get in there within a reasonable amount of time and don't change their minds. Then they don't really like to work with them because they have this mental health issue. And it's just like, it's so hard, you know, you hear people putting down programs like harm reduction as just enabling, and telling people just go get help. It's not that easy. And it seems like it's getting harder. You know, a couple of years ago, it was like, it felt like there was hope. People were beginning to understand, but it seems like recently it's not easy. It's not easy. And I know this from personal experience with my son.
Yes, I would imagine. Yes, we have a client right now who has got really severe physical problems with his back, and he had surgery on his neck in like last January, so it'll be almost a year. And I can only imagine, you know, having somebody cut open my neck and operate on my spine. I can only imagine what kind of pain this person lives with. And I'm concerned about them in suicide, because they're not, you know, opioids are really not easy or available, even when people have a good need for opiates. They're very difficult to get for a lot of people. And I think this guy's in a situation where, you know, doesn't have a lot of money, doesn't feel like he can work much, has a job, but part of that job, like part of what he can't do is twist it all. Well, when you're working and sweeping a floor or mopping a floor, you're probably going to twist a little bit. And so I don't know how long this person's going to be able to maintain their housing. When you've got skeletal problems like that, staying warm is a very big deal. Like if, you know, he's not able to maintain his housing and he ends up out in the weather, being cold and not having heat is going to make all of that worse. And, you know, I'm concerned about suicide, because if that looks better than living like this every day, that's part of what's going on out here. And when there aren't more options for helping people, then those are the kinds of choices that some people are making. So
unfortunately, suicide goes with substance use disorder a lot. Mm-hmm. I had a cousin that took her own life because she couldn't deal with her substance use disorder anymore.
Yeah. Yeah, a lot of people don't see a way out.
Yeah. Yep.
Yeah.
And it makes it even harder when, they, again, takes weeks to get into programs, and we have a long way to go. It seems like we took a few steps back the last couple of years, and we need to move forward.
Yeah, I think, Kim, did you have your hand up?
Yeah, I just want to comment, with the psychiatric and everything that goes on in the hospital and all of the resources that are not available to people that go into the emergency room. They just want to get rid of people. I've been working with a girl for almost 2 years, and I've gotten her into psychiatric twice. I helped her. I walked into the emergency room with her. I see what it's like to be in the emergency room and how they're treated, and how the decision is made from somebody who's on an iPad on the other side. Whether or not this person can go to, any kind of psychiatric service like D6 or anywhere downstate. And a lot of times they're turned down if they use substances. So I advocated a lot for her. I was able to get her into 3 different rehabs. And I know a lot of people are like, 3 different rehabs. And I just talked to her actually today, and she's going into rehab number 4. Since I've known her, but she's been thrown out by the system. Every time, she wants really hard to be sober. She doesn't want to be an addict, but nobody helps with housing or anything like that with her. And so she's stuck back into the same place where she was before every time she gets out of rehab. So it's really hard for, limited resources. I tried to get her into here in Traverse City. We were so close, and then everybody got COVID, so it's, she's displaced again, which isn't the first time, we've applied to all different kinds of places together, and it's constantly, she's homeless all over again. And it's programs like harm reduction that's like kept her alive at this point, with, helping her every time that she relapses to be able to get, the supplies that she needs. And just, without harm reduction, I don't know where she would be at this point, because, at least she is using clean, supplies, and she knows how to. She had the education for that, and I know that she does help get other people those supplies, and she really does want to be clean. It's just she doesn't have any help really from the outside system, and she's going to rehab tomorrow. I just hope that this time around she can have some kind of services afterwards. So she can stay sober. It's just a sad situation where she just keeps getting displaced every time and is just put out to be homeless all over again.
Yeah, I think that part of the challenge too is that, like you said, Kim, people aren't getting the proper resources afterwards. And then the other thing that often is not considered is people's trauma history, because there are people that aren't ever going to be clean because of their trauma history. They just can't envision it, or they don't know how to be here without at least a little something that takes the edge off. And, frankly, that's very challenging when all of the programming is really still focused on Bill and Bob, and 12-step abstinence has to be the ultimate goal, even if harm reduction is the way to get there. Like I hear some people like, okay, harm reduction is okay as long as it's the way to get to abstinence again. No, you know what? When people have a heavy trauma history, some people, I've got one woman who honestly, she's pretty young, she's very smart, she's very capable, and she's chronically homeless, and generational pattern of addiction. And when I first met her, At the previous place where I was employed, alcohol was her drug of choice, and she moved into opiates, and she has since been in a lot of trouble in the last few years with methamphetamine. And, you know, honestly, at this point, I think she's maintaining and not using methamphetamine or opiates a lot. But this is a person who, and she's been housed a couple of times. She's gotten into different housing things, but she always loses her housing because she has other friends who are homeless, who have lots of chaotic addiction going on, come and stay with her. And then she gets kicked out, or people figure out that she's smoking meth in her housing, and then she gets kicked out. And so she loses her housing, even if she's gotten into a couple places, but then she loses it again, you know. And that person came to us on Friday, and she was like, you know, I just had she from her perspective, something has to help her with being here on a daily basis. And so abstinence is just a pretty big stretch for her. What she'll be like in 20 years, you know, maybe at some point she can mature out of the need for something external to medicate with, but I don't know. And in the meantime, does she deserve to die because that's not her goal? No, you know. And it's frustrating, you know, and that's what I feel like I didn't, and that you know, I didn't see really, I often don't see, is an understanding that, you know, when, especially when there's a heavy trauma history, that goal of abstinence is sometimes unattainable.
And this is the only disease that we encounter where the conversation is about us maturing out of that sort of perfection is demanded. I mean, nobody refers to even mental health, which is also heavily stigmatized. And really, I agree, it's ridiculous to separate the two. It is, from my experience, substance use was my answer to mental health. But we don't expect somebody with diabetes to mature out of that treatment. That like the or heart conditions, any of those things. Like, it's just this mentality that this is the way to do it. Like the abstinence-based rehab multiple times, all of that. It just simply doesn't work. In the past long period of time, but especially in the last 20, 30 years, with the rise in overdoses, especially since 2009, like, I don't know how that hasn't been made clear.
I think it is clear. That's the frustrating part to me, is that when it is clear, I mean, the death toll makes it really clear, but, you know, there's just, I think the part that is not clear is connecting the two somehow.
Yeah, I mean, I think that that's an excellent point, especially the perspective of that harm reduction itself is treatment. The treatment process for, again, the only disease where we expect somebody to go into a place for 30 days with all their freedom stripped away and come out the other side and not have no symptoms of their disease anymore. And then if they're in treatment and the symptoms of their disease shine through, they're kicked out of treatment. It is absurd to me that the sicker you are, the less care you're provided.
I agree that too. And the same, you know, the girl that we were talking about earlier, you know, she has severe PTSD. She was involved in trafficking, and, you know, so keeping her homeless and out on the street, and, you know, not only that, but, you know, she was on parole. She's off parole now, but she was on parole. And the whole time that she was on parole, she was pregnant, and she was using meth, but they kept her out of jail because it cost too much money to keep her in jail because she was pregnant. It's just an awful circle of just neglect, I think.
Well, and really and truly, yes, it's an awful circle of neglect, because my mind immediately goes to, where's that baby? And was that baby immediately removed? And what is the status of that child's health, both physical and mental? And who's paying for that child's lack of well-being? I mean, I don't know, maybe the child's perfectly healthy, but if the person was using meth throughout their pregnancy, maybe the child's not perfectly healthy. And then, you know, somebody has to take care of that child. And then we're just perpetuating a generational cycle when our system won't deal with a pregnant meth user who's on parole. So really, we have the authority to deal with it, but they just don't, it's too much, or they don't really know how. I mean, then that's pretty tragic, because there we're perpetuating the cycle without any question. You know, we have it happen in our program too, especially in Cadillac. We've had a lot of pregnant people accessing services through our program. And that's always a challenge for me. You know, I have to really, that's where I've got to like really take my face off of the screen, right? Because I can't be a poker face. I mean, I remember when, you know, Derek was working the desk and he said, you know, that somebody had come in and said that they were, you know, basically in a drug house with a woman who was pregnant and who had been reversed 5 times that week. So I am immediately, you know, I was like immediately like, how pregnant is this person who had to be reversed 5 times this week? Like, is this person at 4 months, or is this person at 24 weeks? You know, I mean, and those kinds of questions. And of course, this person wasn't accessing the program themselves. It was somebody else from the dope house who was coming in to get supplies for all of the people in that house. But, you know, it's been eye-opening. You know, we also had, you know, and thank God the guys at Wexford County Jail, they were trying to be helpful, because we had this other person who was pregnant and in jail, and withdrawing from opiates, except for they said that, oh no, she's not withdrawing. She's not showing any signs of withdrawal. And I'm thinking, I'd like to ask her. And then the sheriff's, like a couple days later, they called our provider. At that time, that day, the provider was not in the Cadillac office. And so the sheriff's deputies actually drove her an hour to get medication, because I guess she was showing signs of withdrawal at that point. You know, but and then we were told that they would be in jail for at least this amount of time. And then I was freaking out because, oh no, she didn't stay in jail for that amount of time. She got released from jail. And if we had known when she was going to be released, we would have been right there making sure that there was Narcan available to that person, and that we continued follow-up after being released from jail, so that we could stay on top of the medication that she was now and newly on as a result of this drive to Traverse City. But we didn't know when she got released, because nobody told us when she was being released, and they had told us she would be staying much longer in jail for the crime she had perpetrated. You know, so yeah, you know, that's sometimes, you know, as a person who's been doing this a long time and a harm reductionist at heart, there's times where, you know, I have to just keep my face off. I'm glad my face is not visible through the telephone, because I'm sure my face is doing all kinds of telltale things about what my concerns are, and I don't want to be judging anybody. But I think, you know, for all of us, no matter where we stand on these issues, there are parts of it that can be really challenging. No question.
Like sending people to prison who have had severe trauma in the past.
I just had a quick question for Pam. She'd said that the harm reduction was in Kalkaska 1 day a week. I'm just curious what day and what location.
Thursday afternoons, and it is, I have to look at the location because I know how to get there, but I can't tell you exactly. You know what, Belinda, can you send me your email address or your phone number in the chat, and then I will send you the location.
Yes, perfect. I will do that.
Yeah,
thank you.
Either that, I can tell her where it's at too.
Okay.
She's part of our coalition, so.
Okay, great. Yep. Like I say, I know how to get there, but I can't tell you exactly the address off the top of my head.
That's how I function, so I get it totally.
We got about 10 minutes left. Anybody else have any questions for Pam?
Hey,
Or
Pam,
Fran.
you mentioned the person coming out of jail in Cadillac that went for Vivitrol. Are you seeing the jails moving in the direction of Suboxone at all? You hope, or is that still?
You know, it's kind of interesting because the undersheriff there in Cadillac is really into helping people. And I had a great conversation with him. We were talking about their naloxone vending machine in the lobby, and he's really motivated to help people any way he can. And I was trying to help him see that from my perspective, Vivitrol is actually really not helping people. It sets them up for death of overdose. And because it, you know, it clears, it totally blocks, right? And then once their Vivitrol is running out, and most often they've been given Vivitrol in the jail, a lot of times not necessarily, it wouldn't be their first choice, let's say that. And then they're released, and then now they do have a choice. And because they've had a total blocker in their brain, they're going to run for like the minute that starts to wear off, they're going to run for the closest opiate they can find. And that's just a primal need at that point. And so long story short, they run for the closest opiate, and all too often it's more than what their body can take and they're dead of an overdose. And so I'm not a big fan of Vivitrol at this point at all. And this gentleman is really motivated to help people in any way he can. So I was trying to encourage him to consider Suboxone in the jail. And I think I will keep on that effort. Because, you know, he was looking for more ways he could help. And I said, you know, I agree, Suboxone is challenging. He said, I don't like Suboxone because, you know, a lot of people have tried to smuggle it in here. And I was like, yeah, well, if you're prescribing it, they don't have to try to smuggle it in there, you know? And number two, you know, the other thing is that, yes, it's heavily diverted without any question. We got a problem with Suboxone diversion out here. Sorry, the cat is rolling against the screen and that's what's moving it. But anyways, yes, there's a lot of Suboxone diversion. However, we're at a place where we've got to decide, deal with Suboxone being diverted or more dead bodies. Which one you want? That's our choice right now. Yes, I agree. It's heavily diverted. And when it was started in this country, like they didn't need to start everybody at 32 milligrams. And unfortunately, they set it up that initially when it started in the US, they started everybody out at 32 milligrams. Probably didn't need to do that. And what happened then is that they had everybody on 32 milligrams. And now, you know, that person could take their 32 milligrams home and share it with their partner or their roommate. And so that's how, you know, like that was the beginning of Suboxone in this country. And so we started off at probably too high of a dose. But either way, you know, it's okay. It's, again, we're in a situation where a lot of diversion of Suboxone or more dead bodies. And I vote for Suboxone. I mean, nobody's dying on Suboxone or not. I mean, unless they're combining it with a lot of other things, most people are not dying on Suboxone. So it's a better answer.
Okay. Oh, sorry. Go ahead, David.
How's the naloxone vending machine going?
It's, you know, it's in Baldwin, it's a bit of a slow go because we haven't done a lot of get the word out. And so, but I think, you know, in other places it's going quicker. So.
You said the Cadillac jail?
Pardon? Yeah, it's in the Cadillac jail lobby. And so I'll be down there on Friday. I'll check back in with them about how that's going, you know.
Nice.
Pam, about a little over a month ago, myself, Tim Shoecraft and one of our physicians at MOC, we met with Wexford County Probation Parole to discuss Suboxone and kind of what they were seeing and how things are going. And they brought up the vending machine in the jail. You know, maybe that's something we could discuss offline, but maybe we could partner with you and have one of our physicians and you meet with the undersheriff there in Wexford to discuss Suboxone in the jails.
Yeah, that would be great because I tried to encourage him in this conversation. He had called us about the machine and about making sure that people do that after they, you know, if they used what they got in the machine, that they could get more afterwards from us. And, you know, that was what we wanted to make sure there was a seamless flow of information there. But it was a really long conversation, and the guy genuinely struck me as very motivated to do what he can to help people. And he said that 2 or 3 times. And I was like, well, here's something you can do. But, you know, oftentimes they don't want to hear, yeah, hearing it from you guys would be helpful because, you know, they don't want to hear it from a social worker.
And a few points there with the individuals leaving jail having received the Vivitrol. Not only have it been the blocker and not providing any of that, the treatment for the actual damage to the reward system, but they're offered no wraparound services when they leave the jail. Say transportation is an issue for them, which it is for a lot of people with substance use disorder, especially a lot of people with substance use disorder that have criminal justice involvement. How do they get to that appointment?
Right.
There's no support there to help follow through with any of that.
Mhm.
And to the point with buprenorphine wouldn't be smuggled in if it was prescribed, agree completely. There's also a lot of studies that show that a huge driving factor in the diversion of buprenorphine is that there's no one prescribing. That when prescribers increase in an area, diversion decreases significantly.
Mm-hmm.
I think
Absolutely. We didn't expect in Cadillac when we opened, we really didn't expect. We've had more people calling us and coming through our door looking for MAT than syringes, like overwhelmingly. A lot more people looking for help than looking for syringes.
I believe Life Works in Kalkaska is working with our county jail, so anybody that's on the MAT can continue to stay on it, so they're not detoxing off of it in the jail. I don't know that new patients are allowed to be put on it yet, but that's something I could find out. And I think Vivitrol is being offered as well, but I don't.
Some of the jails in Southeast Michigan, I know, namely Monroe County, they've had a lot of success with their naloxone and the vending machine. But they partnered with a methadone clinic in their area where they will actually initiate methadone treatment in the jail.
That would be fabulous. You know, methadone is cheap, and it really we could be using it a lot more than we do.
We only have one provider in the area, correct?
Well, that's
Depends on how you define area.
well, no, we have 2. There are 2 in Gaylord.
Oh, is there 2 in Gaylord?
Mm-hmm.
But people from here, it's an hour every day to go get their treatment.
Right.
Yeah,
right.
methadone treatment could be so beneficial if we increased more, but we'd also have to reduce so many of the restrictions, so many of the regulations. I know multiple people that have been on methadone treatment for years. Mm-hmm. And have really built successful recovery and established lives that they're proud of, but have to go to the methadone clinic multiple times every week. And it's just a huge hindrance in their life to have to do that so often. It like restricts how employment opportunities because they have to be able to make it to the clinic. Can't really just go on vacation whenever they want the way people who don't have methadone treatment can, because you know that they have to be able to be there to get their dose.
Mm-hmm. Yeah, I would like to see maybe us organize about methadone in Michigan somehow. You know, it's something that I think could help a lot in a lot of places, and but it'll take some organizing for sure. So yeah, we have a guy. Go ahead.
Oh, just a lot of those regulations are federal. Mm-hmm. A lot of the things that it has to be at a specific OTP clinic, that it has to be the limited take homes, all things like that are set down at a federal level.